So welcome here back after the coffee break, and we can start the live cases number 3. We have again 3 cases simultaneously, and we will just go to lab number 3 in ICAM, and they are doing AFib ablation using farawave. Drago, slyšíte nás?
Jo, slyšíme se. Okay. May I start?
Yeah, you can start, definitely.
Okay, so greetings from ICAM. Today we are here with Dr. Štavnický, and we will present you the case of persistent AF. It's a catheter ablation using pulse field and farapulse. Can we show the next case? So our patient is 72 years old, male, with many comorbidities. He actually has a metabolic syndrome. He's obese, and he has a heart failure with preserved ejection fraction. He has a very high level of anti-pro-BNP, and this arrhythmia is persistent. However, now he is in sinus rhythm, but on amio. On echo, there is a mild dilatation of the left atrium. Otherwise, its echo is unremarkable. Can we show the ECG? Okay, so this is a ECG of our patient on admission. You can see that during sinus rhythm, these P waves are very long. Next slide. We measured. It's about 165 milliseconds. So this can be a sign of interatrial conduction delay. And so for today, I will show you first the transeptal puncture. Can we show the ICE 11, please? Okay, so for this case, we use an RG needle. If we can show on the camera. It's a needle from Bailey's Boston Scientific. It has a rounded tip that prevents skiving and potentially reduce the risk of embolic events because of the microplasty going into the left atrium. It's a RF needle, so we very easily cross the septum, we advance the sheet, and then we exchange the sheet for the Farah drive. Okay, and I will show you the anatomy. We are using ICE, so this procedure will be ICE guided and facilitated with fluoro. And I will show you just the anatomy. Můžeme live? Can we show the live? Okay, so in this patient, we have a left common trunk. It can be challenging for ablation. We measured it's about 21 to 25 millimeters, and we put inside actually Farah wave 31 millimeters, but it was too small to cover the whole ostium, so we exchanged the catheter for the 35, and I can show you how it looks like when it's in basket position. So can you show me this, please? So it's a very big basket, but it's covering basically the whole common ostium. So probably it would be easy to do. And what is planned for today, for this case, we will do pulmonary vein isolation, then we will do posterior wall, and we will induce. And we will see what if we induce atrial tachycardia, we will chase this tachycardia probably. So we will see. And I also wanted to show you the signals on the anterior wall. So it's very easy to go. Show me this. Okay. So I just counterclock the sheet. I do a little bend, and I'm basically on the roof part of the anterior wall. And you see that these signals are a little bit fragmented, but nothing special. And so that's it for now. We will start doing this procedure, and we will start with the PVI. Yeah, we can show. Yeah, exactly. We can show the same position from the ventricle, and this is. May I? This is for Dr. Razminia. We look at this pulmonary valve. It has very redundant cusps. I don't know if this meaning something, but this is only incidental finding. This is the projection. This is a short axis projection. So I will go on the anterior wall, and then you can see that my flower is pushing the anterior wall against the aorta.
So just might say that we don't change size of the paravate catheter during procedure. We did far more than 1,000 ablations. I think only few cases, maybe one or two, we change the catheter during the procedure. It's because of workshop probably.
Jo, jak vypadá? Yeah. So here is the appendage. You see? Okay, this one to the... Může mi dát normal view? Okay. So now we will go to this common trunk, and we will show you the projection directly from the, yes. So here you see that the whole basket is deployed into the left common trunk, and now if I do a flower, you can see just based on the X-ray that we don't know if we are in good position, but on the ice you see that half of this flower is actually in the appendage, and this can be dangerous because we can isolate the whole appendage. So we can fix this just by pushing or rotating the sheet towards the posterior wall, and now you can see we are ready to ablate in this position. It's much better than we saw previously. Okay, are there any questions?
It doesn't see so.
I have only a single comment that the IC enables to nicely positioning of flower catheter because it may be either oriented against Marshall ridge, like pushing from anterior, from the appendage aspect, or it may be hooked inside, so you can ablate Marshall tract from both sides where you are able to visualize this.
Exactly like that. So we gave patient atropine. We can start our ablation. Wait a second. Okay.
Can I have one question? Sorry, Laszlo Geller from Hungary.
Wait.
Do you hear me?
Yes.
Yeah, I hear you.
So my question is that you mentioned that you started with a 31 millimeter catheter, which has been changed to a 35 millimeters, right? What do you think about the possible usefulness of preoperative CT or any kind of imaging? With that, you can, help yourself to select the catheter appropriately according to the findings of the appropriate size.
Yes, good comment, but these are rare cases, and in addition we have ice, so based on ice we can choose the catheter, but I just wanted to show you that with this catheter is much better. We can do this with 31, but the reason why we took 35 because it's much easier to do. But it can be done also with 31. You have to reposition the catheter, but it can be done also with 31. You can do this biscuit shape that can cover the whole ostium, but I think with this catheter is much more easier. And also right-sided pulmonary veins, if you see it on the ice, they are very big, very large. There is a lot of room here, so I think this catheter will be appropriate also for the right-sided veins. This is the right inferior, and right superior is, we cannot visualize it right now, but it's also very, there are a lot of room for this catheter. So now, if there are no comments, we will start doing ablation. Can we show also the activation of the appendage? Usually in those, this is elderly patient with persistent arrhythmia, and in those patients we are also checking the activation time of the appendage. Can we show the appendage? not pacing, yes. We are measuring this LAAQ interval. So it's from the sharpest signal to the beginning of the QRS. And if this signal is delayed or in the QRS, it means that anterior wall is diseased. Okay? So I think now we can start doing our ablation. Let's ablate here. This is very nice view. Okay. And you see the small separation below the LA. This is not a pericardial space. This is a CS with this decapolar catheter. Okay, so we did 2 applications, a little bit more inside. I will rotate my catheter for about 35, 36 degrees, and we will continue. We will put 4 applications a little bit deeper inside, and then I will pull back a little catheter, and I will again do this ablation in basket shape. So this is a 4th, okay, so I will make a little bit bigger basket. I will go back, okay, you see that we are covering the whole ostium, and you see the signals as well when I move back the catheter. Yes. And you see the utility of the eyes. Just based on fluoro, look at this. You don't know where you are. So there is no chance to know that where your basket is deployed. Okay? I will rotate the basket again, and then we will go for this flower shape, but from the ventricle. Okay. Go here, go here. So we will go for 2 applications. So we are ablating this carina, you see, from inner side. And as Dan mentioned, then with the flower shape, we will ablate from the appendage side. Okay, so we have now 8 applications. Let's go for the flower. Okay. So, and again, if I just push the catheter, you see that my whole spline is in the appendage. So without eyes, you cannot see this, I believe. So I push my sheet to be in contact with the flower. I bend a little bit, and I clog the catheter, obviously. Okay, so you see that one spline is touching this carina. Yeah, and also you see the signals. Okay, ablate here.
If there are any questions during the case, I don't hesitate to ask.
Let's go. Okay, so I will rotate, and obviously we will do this anchoring lesion because we are planning to ablate the whole posterior wall. And maybe you probably see our X-ray. You see that quality is not good, but not because of the X-ray machine, but because of the setting. We are using ultra low flow fluoro, and we are using only 2 frames per second. Okay, we have. Okay, let's show from the right atrium the projection. Okay, you see that now we want to cover also this lower part of the vein. So I need to bend more this catheter. Okay, you see that now we are in good position, and there are also signals. And let's go here. Okay, if they want to, in the EP Lab 4, they are also prepared. So if you want to go there, we will just finish the veins, posterior wall, and then we will induce, and then we can come back.
Okay, we agree.
If it's okay. Okay, so. Tak teďka uděláme ten anchor.
So we are going to another lab in ICAM.
We already see you. Yeah, it was switched to you.
První slide, prosím.
I think Peter will introduce you the patient.
So, hello again. We are here to show another Afera case. I'm here with Joseph and Eva Borishinsova. And if we move to see the, yeah, we need to put her in the, she's somehow below the level of the transmission. But we like her very much. Okay, so we have a 77-year-old male with comorbidities, and his main diagnosis hypertrophic cardiomyopathy with apical obstruction, with normal ejection fraction, and dilated atria, LAVI of 75. And he has a history of persistent AF, so some years. He had 2 ablation procedures. I will go more in details in a few minutes or a few seconds, but this is the therapy. He's not on any antiarrhythmic therapy because he didn't tolerate it, and he has some thyroidopathy. So if we go to the next slide, I believe this is important to mention what was done, and it's important also for us. So PVI was done first by RF. That was 3 years ago. Then we, as a redo, used FARAPULSE system. We found reconduction to the veins. We re-isolated, and we also ablated through the posterior wall, and then cardioverted. And we attempted to do ablation on the mitral isthmus with FARAPULSE, which sometimes is difficult, especially in hypertrophic cardiomyopathy patients. The thickness of the muscle may be bigger than usual, and we were able to block it for some time, but there was always recurrence. But nothing was inducible. That felt like, let's see what will happen. And as you can expect it, there were always atrial tachycardias afterwards. Can we move to the next slide? So this is the, can we move to the next slide, please? So this is what he had in 2023. Regular rhythm, definitely not a sinus rhythm. If you really watch carefully, you will find the second P wave, something can be overlooked, but unfortunately, we know it's not a sinus, so this was 2-to-1, and this was a very stable rhythm for about a year. We were negotiating to do another procedure, and then we said, the Affera will be able to do it because it will be complex, but this is the system that may allow to do us. So, although he was for and there was one cardioversion which didn't help, so he was 1 year in this arrhythmia. If we go to the next slide, surprisingly he came in a sinus rhythm. Sometimes you get surprises, but obviously there's a substrate for arrhythmias. So we started with in the sinus rhythm, and Joseph will describe if you put up the Affera screen what we found during the sinus.
Maybe we can see the Affera sinus
Affera map.
So on the left side you see activation map, on the right side you see a voltage map. And to map with this system is very easy. It's actually very intuitive. You can lock left veins and against the appendage. So you have, we will show you in the next map, because in this map we just did brief mapping. And you have a very nice anatomy of pulmonary veins. If you look at the left map, you see that veins are black, and also a big part of posterior wall is black, which is a voltage below 0.03, which is practically scar. And there is some like channel on this activation map in posterior part, close to right veins, which we were not sure if it's really going through because of the activation goes like from both sides. And then we also looked at the mitral isthmus, if we can see it, if we can rotate clockwise to the right. So you see that there is like conduction which goes up close to appendage, between the appendage and vein there is some activation. So it's pacing from CS5-6, so somewhere down below the isthmus. And so our conclusion is that there is leakage across the mitral isthmus, and there is possible channel of conduction posterior wall close to right veins. And if you look at the voltage map, everything will be red more or less on posterior wall if we can rotate. So yeah, that's, but you see also on this right side that there is maybe some yellow island, and above is some green island, so that may correspond to some channel of slow conduction for some roof-dependent atrial tachycardia. And yeah, and then we induced tachycardia. Maybe Peter can comment on tachycardia map. First we log this vein, so you can see if you can make it bigger. So you see the anatomy of ridge between appendage and left veins is pretty accurate. You just go inside the vein, and when you slip out, and we checked always on the intracardiac echo, so you can do very nice anatomy of this ridge, which is really in between left veins and appendage. So we checked from both sides, we mapped carefully this isthmus, and then remapped during tachycardia. So now you see the maybe on the running screen you can see the tachycardia, which has earliest activation in 5-6, suggesting that this is not perimitral. And we already know that there is this channel, potential channel on posterior wall. So it looks like a roof-dependent flutter. So Peter can comment on this map.
So maybe if we start with AP view, AP with the activation and tilt it down. So generally we want to really look where the activation comes from in different segments. So if you really look at the anterior wall, it comes up and down. But if you look where it starts, it suddenly starts out of the roof. And there is also the violet color. If you just look at what's the early meets late or where's the violet and red, it might be misleading. But generally you look at the segments and there's a suddenly out of like activation. So it seems to be coming something from the inferior wall or the posterior wall coming up to the, so that's definitely the activation of the anterior wall. If we go PA, then we see a collision of two wavefronts, rotate to the left. Okay, so you see two wavefronts from below, they collide to the posterior wall. So generally it's a roof-dependent flutter, not much to say. So maybe Joseph will go back to comment on the strategy.
We decided to go to this channel and try testing pulse. If we can interrupt, and if yes, then we will close this channel.
Reversible pulse, which is very short.
Reversible pulse. You see very lovely, maybe if we can see signals, you see lovely fragmented long signals, maybe even long.
Okay, yeah, that's still nice.
Yeah, it's a very nice area here. So we can deliver here this testing pulse of pulse field. And then we will treat this channel, and then we will finish mitral isthmus with RF, because it has higher penetration probably in that area, we know from our previous studies. And then we try to induce. If we cannot induce, then we will finish with CTI on the right side. CTI typically, if you do with RF, could be like 3 applications or 4 applications, so each of them few seconds, so it's really like 5 seconds, 5 seconds, 5 seconds, and you are done. So let's try here.
So maybe go on. You see the running screen down on your Afera picture. So maybe I will try to deliver. That's a very short. That's a very short artifact, and we'll see what's happening.
Can you give them running screen?
They have down there the running screen. Or if you want to see the electrogram, it's possible. But maybe let's do it. So I will do it right now. So. Yes, it seems to be in contact. Možná to dej malinko ještě níž a zkusíme tady. Okay? So I go, yeah? And didn't help. So maybe this is
maybe the channel is bigger.
Is bigger. So maybe we can go with maybe go lower and we go with full pulse, because this is really short. So maybe we can try different these short kind of pulses here. So let's try here. Can I? Mm-hmm. It didn't help, so maybe go to more to the lateral or up, and whether this is yeah, it's lower. Okay, it's difficult to know. So the short pulse, if it's a deeper or thicker tissue, it's a very.
The other option would be to do entrainment, but obviously we
don't want to destroy
that
the tachycardia.
We terminate.
So I'll try one more here, but I'm afraid that it's not going to help. So
but maybe it's even slower, I think.
It's getting slower, maybe. So if you maybe go higher up, then we will terminate it. Maybe the upper one will be this one is, yes. This I really like. Because this is where, yes. So can we try here? Yeah. No. So then we can try the full pulses. So let's go for the
Peter.
normal pulses.
Peter.
These are really small ones. So maybe we can just draw a line to close the box
Peter.
lesion, and then we'll see.
Please try entrainment, just to
close
know.
some.
Okay,
So change for the normal pulses, like 4 seconds.
Can we see entrainment, just to be sure that... Can you hear me?
Can I try? To Yeah. So we needed more power. Yeah, maybe you can, yeah, there's a double, okay, you can paste from the CSR. Now we finished the roof line and the bottom line, obviously. Let's go here. Okay.
Ukaž mi to pořádně.
Dolů to dej malinko víc.
Jo, tady, čekaj.
Možná to dej vejš, ty linie ještě.
Tady.
Tady, můžu?
Jo.
So we still don't know what the short pulse should look like. There's one pulse, you can upgrade to more pulses. There's a difference between the one pulse, which is this reversible one, which is just one, and if you go full, like pulse field 4 seconds, it's 4,000 of pulses. So if one pulse doesn't do it and the 4,000 does it, it means generally, okay, you just needed more power. We wanted to show you the short one, but
Tady.
můžeme změnit tu temperature.
Okay.
So there's a question.
Maybe close the lower one.
Can you get microphone, please?
We will go to this area again.
Peter and Joseph, do you guys hear me?
Yes.
Okay, Mansour Azminia, excellent case as always. One quick question, what's the rationale behind to give a short pulse?
Generally, it's just to demonstrate that the capability of the technology if you are in a very narrow, in atrial level, in my experience, it usually works. If it's a very narrow channel, you can verify that this is, for example, if you're thinking that this pulse once you deliver, it's difficult to go back. For example, if you don't want to isolate the appendage, if you're in a situation that you're not sure whether this pulse will isolate the appendage or not, you can do this reversible. It just confirms it's another way, like entrainment, that confirms that this one is in the circle.
There are no signals now in this area, which is now isolated from both sides, as you can appreciate. I'm moving the catheter in the middle of this area.
Do you see the electrogram now, please? Can we go, Bruka, big screen?
There are actually no electrograms, so I'm pretty sure that we did our job. But we can remap afterwards. So now we can go to mitral isthmus.
So yes. So go, and then we switch to the mitral RF, which is all the system can give you.
Show me the isthmus.
Now we're
area.
using the maximal powers of the... No, dobrý. So generally this is very early on. So can we go to the map of the sinus or the pacing, which is exactly now the map? So maybe it will just give the audience. Můžeme změnit tu mapu, prosím, tu, co jsme dělali sinusovou? So this is the red is the early, so it's the CS pacing, and it's quite early here. So we can kind of draw the line from here to the mitral. So this would be a nice and stable location, and we should see this location. So this will be for 5 seconds RF. So let's deliver now. So I will start to deliver RF. So we're using 400 watts now.
Different sound, you see?
But it's still,
Here.
and is it block? Maybe if you go above? It's not. So go more closer to the valve. There's not much anymore.
Why you don't see the map?
Well, can we go to the map for the Regie? Okay, there's a technical issue from showing from the Afera, so we will continue to deliver more ablations on the mitral isthmus. So can I go here?
Yep. If you can see maybe intracardiac echo, can you show them intracardiac echo? Okay, yeah. You see the catheter is like if it's attached with glue on the isthmus. No slipping because it's a rough surface. So this is another feature of the catheter which really is very easy to manipulate, and it's very stable because where you put it, it's sitting more or less.
So can I go here?
Yeah, perfect, please. This is now close to the valve, you see, but it's a very stable position of the catheter, as you can appreciate. And I believe that we have some block already, but let's check.
We can add some more.
Yeah, we can do in between here, maybe here, yeah. Tady. Uh-huh. So this is a very nice stability of the catheter, something completely different from a solid tip technology.
And here?
Mm-hmm.
So we still don't have a map.
We can show you now signals. Can we go to running screen? I go above the
Still something. So
still
maybe we can
something.
go slightly above the line.
Below or above?
Above. That's the earliest. Or we can do a remap just above to see where's the earliest activity. So can we do a remap, short remap of the activation? Sorry, there's a technical issue that we cannot show you the Affera map. They're working on it, so just a few seconds.
We still have some.
But can we do a remap
signals
here just to be sure where's this? Please, in between we can remap, please. Can you do a remap? Okay, so collect and just go to the appendage and see what's the earliest here. This is later, definitely later. So go back to the carina. This is early. Can we put the activation like this? Yes. And can we go really to the ridge? Just a little bit to the pull back ještě. Okay, this is now on the ridge. Okay, so this is close to what we found as a potential gap. So we can do, or we can use 4 pulses of pulse field here.
Maybe you can show now ice again to see that we are really sitting now on the ridge, which is even in this nice map you cannot see perfectly because it's virtual reality, but this is reality. This is very important for Farapulse, for Affera, for every technology you use. Without that, it's naive that you are on the right spot with X-ray and angiography. Yeah, no way.
So we'll do. Can we go back to the Affera map? So we will do another application close to the ridge. We saw it.
We are sitting on the ridge now. Yeah, you see it. Without seeing, you don't know where you are.
So can we go above now?
I go above now. It looks it's prolonged, but not that.
It is.
So how much is there? Yeah, it's not yet.
Or we can do 4 pulse field applications in here. Or we can go to the CS. That's another option. Or we can go below. See, it's a thick tissue, so it takes sometimes more time. Do not maybe map below. Just go above and maybe do 4 applications of pulse field to the earliest activation there.
Okay, so I'm above now. You can do pulse field here.
Yeah. Yeah.
Skloněme to trochu.
Is this the earliest? No, this is not the earliest. That was the earliest of the red. Yeah, like closer to the line. This was one. So let's switch to the pulse field and we do 4 pulse field applications here. Can we change to the pulse field?
Double step on pedal.
So now we do 4, yeah? Okay? Počkej, jsme se posunuli, ne? Možná ten šítek blíž k tomu.
Já jsem blízko.
Okay.
Počkej na to. Jsem chtěl si...
Okay.
Počkej.
Just have some electrograms that we use for.
Here we are now, sitting there very nicely. Okay?
Okay.
Yep. No, dobrý.
So that was the first one. Can we just go a little bit better? I'll do a second one. Can I? But once you stabilize, tell me.
Dobrý.
Můžu? Second one, third one, and fourth one. Just please stay at the same side. And the fourth one is coming. We want to wait a little bit between these applications, so it takes 5 to 7 seconds. So maybe move above this one. And it's blocked.
Now it's blocked.
Can you see the electrogram in Pruka?
Show them running
yes,
screen.
we can see it now. We agree. Can you measure it?
No, we can. There was very early activation. Now, can we remap now? Just the whole shortly around the tricuspid annulus or mitral annulus. So we just generally this will be very early, yes, and the activation goes. Maybe if you go to the anterior wall more, just goes to the activation of the anterior appendages like this. Můžeme to otočit doprava, budeme před appendage. We just need a few seconds, and then we will go back to Predrag. Okay, so pull back just to see that the activation goes like this. But the delay is so huge, so I believe that we can say that there is a block. Okay.
Okay, we can review.
So you see the mapping goes pretty quickly.
Okay.
Okay, so you saw the mitral isthmus mark. Definitely we wait whether this will stay, and then we try to reinduce. Okay, so see you later on.
We will go to Predrag lab because I think that already finished the case.
Already. Almost, actually. Still live.
Drag, you are online already?
No.
Yeah. Yeah, do you hear us?
No.
Yeah. Exactly, typical case. We did PVI, we did posterior wall. It was very easy actually to ablate with this 35 millimeter catheter, and we very easily induced this arrhythmia. So we have tachycardia with cycle length of 300 milliseconds. With concentric activation, we put our basket into the, first we did entrainment pacing from proximal CS, and you see that PPI is very long, but we could not cannulate the great cardiac vein. We are only basically in CS, proximal part. So the entrainment from the proximal CS was bad, very bad. But let's take a look on the entrainment from the appendage. So this entrainment was really nice. You see, basically we are in the, okay, you see here. And then we put our catheter on the anterior wall, and you see on live screen, you see the signals. Do you see it? Yes. So you see that we have very fast fragmented activity on the Bachmann bundle. So my question is, who would ablate here for the audience?
Yes, please.
There is some polarity change in 4, 5, 4.
Are there any comments or questions?
I would search for even better signals, because these are not not bad, but
yes,
definitely there should be even better ones. Because if it is localized reentry from anterior wall, it should be, because appendage was all right and proximal CS was not all right. So this can't be macro reentry.
Exactly. So this is probably micro reentrant activity from the anterior wall. So let's search for the better signals.
If there
here
are
on the proximal bundle.
Of course, if there are any. If there are not, just wait there.
Are you able to do
this is okay for me.
With this catheter, just to quickly, map the atrial tachycardia, just doing an activation map?
Yeah, it is possible, but this is only the conventional ablation case, so without 3D mapping. But I think with these 3 entrainments we can know or suppose what is happening here, and I really think that this is arrhythmia coming from the anterior wall, and as I showed you, P wave was very long, so there is probably some interatrial conduction delay, and these signals I really like here. So I will ablate here.
Yeah, I mean, the polarity in 4-5 and 3-4 just changes, so that's a good time, yeah, probably to stop it, hopefully, no.
Okay, so this is a first application, so let's put one more here.
It definitely slowed down.
Yeah, exactly. Can we measure the cycle length? Oh, it's actually the same.
No.
Bless you.
So let's try here. Let's go here, ablate. Can we measure one more time? Yeah, another application. Okay. So let's check. Maybe this is some another tachycardia. Let's go again to the appendage because it can change. Okay. So now we are in the appendage. Can we do entrainment for from appendage now? Okay, stop. Okay, so this is pretty good. So let's search for more signals on the anterior wall. Okay, let's go here. We are close to the annulus now. We are close to the aortomitral continuity. Let's go here. Okay, one more. Let's ablate here. We have two. One more.
Já bych navrhl, že jsme ho tam nechali.
Okay. This is also very nice. Let's go here.
Drag. We suggest to leave you mapping and find.
Okay. We will finish the anterior wall and then we will see.
Another lab. Do you agree?
Okay.
Do more entrainments.
Yeah. I will just finish anatomically anterior wall.
All right, so we go for Homolka for a while. Vivek is ready with this life in the box case.
Voila. Hi, can you guys hear me?
Yes.
Fantastic. Okay. Oh, wrong slide. Wrong. Okay, good. That was that was a wrong title. I apologize, but these are the right disclosures. I'm going to show a case that Peter and I did a couple of I don't know, maybe a few months ago or maybe longer. I can't remember, but it'll be a case of the Sphere 360 catheter, which is a single shot type of catheter, and I'll go through that. Please note that the catheter that we're going to talk about does not have regulatory approval in either Europe or anywhere in the world. So all of you are aware of the Sphere 9 catheter. We've seen it now several times between cases yesterday and today. It's a catheter that's a 9 millimeter mesh delivered through an 8 French catheter, and it has a compressible mesh, and it's used for point ablation for the atrium or the ventricle. That can deliver either RF or PF energy. The company then also created this other single shot catheter, and this is only pulse field. This cannot deliver RF, so it's different. The idea here is to make a larger mesh electrode, 34 millimeters in diameter, also delivered with the 8 French catheter. This catheter has an expandable, compressible lattice framework, and it's an over-the-wire system. So you can go to these different dimensions. It has 6 different sections, and I'll show you that are energized from monopolar pulse field delivery. There are also some mini electrodes. You can barely make them out here, 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 here. And these mini electrodes allow for mapping as well as stimulation. There are magnetic sensors in here to allow for electron-anatomical mapping. And there are radiopaque markers for visualization on X-ray. It is, as I said, guided by the Affera electron-anatomical mapping system, as shown here. And once you're in position, you can create the map, create an anatomy, as well as deliver PF energy, which are 5 seconds per application. And the goal is to deliver about 4 lesions per pulmonary vein. Let me take you through a case. So this is all part of a protocol, a first-in-human protocol. It is a 60, doesn't say right here properly, but it is a male paroxysmal atrial fibrillation patient. And let me take you through the case. So first I just want to show you the catheter itself. So to connect the catheter, there's 2 electrical connections there and there. Then there's this central lumen that you flush with saline. And then what we'll do is we'll load the lattice. Actually, here you see the injection of saline through the tip. And then here we'll load a guide wire. And we just use a typical 032 or 035 guide wire. We tend to use an 032 guide wire with a J tip. And once it's loaded, it comes out of the back end here. And now you're ready to introduce it. So in this particular patient, there was a conventional transeptal puncture that we performed. And here we used a deflectable 8.5 French sheath. Now we're going to load up this device. So this is the introducing, oh, I'm sorry. Let me just step outward again. This is the, let me just show that one more time. This is the introducing mechanism. We pull the device in, and then we'll introduce this to the sheath. And after we introduce it, we make sure that we aspirate, because we'll break the septum, aspirate, make sure there's no bubbles, and advance this into the chamber. So let's take a look at this. I'm going to pause this for a second. This is obviously the electron-anatomical mapping system. You can see on the fluoro, there's a transeptal sheath and a coronary sinus catheter. There's also an ICE catheter, and you'll see the ICE images and the mapping system here. So, and this is the actual catheter itself. It's opened up in the left atrium. Here you can see on the ICE. And here you see the guide wires with advanced the left superior pulmonary vein. We advance this. Here, this is a posterior view, and over here is a top-down view. And these are electrograms, by the way, from the mini electrodes. So you can see after going to the superior, we deflect the sheath, and we're going to take the wire, advance here. You see the wire itself, advance to the left inferior pulmonary vein, advance the device. We narrow it down with an actuator on the handle to make it more elongated, as you see here. And then as we pull back, we can render the anatomy on the left side. Now, this is what we typically do. Once we render the anatomy of the 2 veins, we tend to start ablating. So now we're in the chamber, and we're going to start ablating in just a second. And we like to deliver about 4 applications per vein. So what you're going to see here in a second, we advance this into the vein and to our more distal-most position. And again, we're not worried about PV stenosis. So we'll put this in position, a location that we like, and then we're going to deliver energy. And when we deliver the energy, you're going to see some artifact here. Again, these are the electrograms from these mini electrodes, the 6 mini electrodes. You're going to see a lot of artifact. There's the artifact that's starting. So this is the first 5-second lesion. And at the end of this lesion, you'll see that the electrograms disappear. Again, not surprising for pulse field energy. That was the first lesion. You can see the sort of the ghost in yellow of that first lesion. Then we withdrew a few millimeters to do a second lesion. And then we're going to pull back again here, open this a little bit bigger to deliver a more proximal lesion. So here you see the electrograms because now we're more proximal, obviously. And you can see on the ICE the position. And we're going to deliver a lesion here. Now, if you notice, here's the first 2 lesions. This is going to be the 3rd lesion. It's a little further back. So what we do here is deflect, make it a little smaller, and we deliver one in between. So a total of 4 overlapping lesions, each around 5 seconds. So that is ablation of the left inferior pulmonary vein. Then we go to the left superior. So we're going to withdraw the catheter, as you'll see here on the ICE image. And then we'll take a guide wire and introduce it into the left superior pulmonary vein. Didn't go there, so we'll probably withdraw a little bit more. There you can see on fluoro. There you see the J-tip, advance the guide wire in the left superior, advance the device over the guide wire, and you can see that here on the mapping system. By the way, I've been talking continuously now for about 5 minutes or so. If there's questions, please interrupt me here. This, by the way, is a clock that's just showing the time. The clock was started at the beginning of the first lesion. So you'll see sort of the run time of the transpired ablation time. So again, same strategy. We deliver the first 2 lesions up here. Then here we position again for the 3rd lesion. And for the last lesion, you're going to see we're going to make it the biggest lesion. You see it almost like a pancake. So you can see it here. It's brought quite far back. It's a pancake-like shape, as you'll see here. And this will be all 4 lesions. Now, once we're done with these lesions, these are the left veins. So then what we'll do is we make this into a big pancake, as you'll see here. The first thing I do, as you can see on ice, I pull it back to the ostium, to the transeptal puncture site, then sweep it around. As you sweep it around, you can see you can render the left atrial anatomy relatively quickly. Again, I'm not at all focused on electrograms at this point. I'm just simply rendering the anatomy. And because of its large structure, you can actually render the anatomy fairly quickly. And then we're going to go toward the right superior pulmonary vein. So I push the sheath right close to this. Oh, actually here, I'm going to still doing the anterior wall anatomy. And then we'll turn it, I guess still rendering an anatomy. And then we're going to go toward the right pulmonary vein. So here you can see on the top-down view, a little bit anterior, advance the guide wire, now advance the catheter. There we render the vein, and then pull it back a little bit. So this is an RAO view here, an AP view on the left and a top-down view on the right. You can see the electrograms here. This is a reasonable place to consider the first lesion. So now we're going to start delivering energy here in just a second. There, the artifact over the 5 seconds that you'll see here. Then pull back again. Comes the next lesion. By the way, I didn't talk about this number here. This length shows the distance between the first lesion and the next lesion. So this one actually we pull back a little bit more. So that first one was more inside the vein. So here we pull back a little bit. Then make it again a little bit bigger. And then here I think I wanted to deliver one in between these two. So we made it a little smaller there. And deliver this. So that'll be the 3rd lesion here. And then the 4th lesion will make it much bigger. So here, make it almost like a pancake. Here what I typically do is get the sheath right behind here. You can see on the top-down view it's clocked a little bit so that we get some of this anterior portion right here without extending too far anterior. You can see on the fluoro that one of the nice things about this catheter is that it is somewhat conformable. So it conforms to the tissue to try to optimize tissue proximity to deliver the energy. So we're done with the superior veins, then the right superior. So pull the wire back, deflected. Here on the posterior view, you can see this. And then what we're going to do is try to wire the inferior. You can see we're sort of in a superior branch of the inferior probably. You can see on the top down view, it is the inferior branch, but this is going to be a superior branch of the inferior. Not really the ideal position. So at this point, there are a couple of options. Probably the easiest option is to make this device smaller, pull it back into the sheath as you see here, then withdraw the wire counterclockwise slightly and advance the wire. Now we've wired the inferior branch, and then you can track this over easier. Back out the sheath, and you conform relatively nicely to this inferior anatomy as you see here. Again, you see the electrograms. This vein has not been touched yet, but in just a second, there's the first lesion. The energy is being delivered, and again, the same strategy. We like to deliver 4 overlapping lesions. So that's the first one. This is the second one. And here on the ice, you see on ice, of course, and you also see it on fluoro. Just like any other procedure, we really do like ice. I think it really enhances the the quality of the procedure. And then this is, I think, is going to be the last lesion. We make it the biggest. And here we can see on the top down, we've deflected anteriorly a little bit just to extend the level of isolation. I don't know if it was necessary to go that far, but anyway, that's what we did. So those are the lesions. And I think maybe there's one more. I think the last lesion now, we counterclock a little bit, go a little posteriorly. Oh, sorry, let me put that in. We counterclock a little bit, deliver posteriorly. This is the last lesion. And then once we do this, we can check the veins. You know, because these are mini electrodes, we can advance, for example, the catheter here into the vein and actually pace from the mini electrodes. I mean, I personally don't know that it matters that much. With pulse field, I don't think I've ever seen unidirectional block. If you have entrance, you have exit. If it's going to reconnect, it's going to reconnect later, unfortunately. So we can pace from all of the veins, which is what we do here. I'm just skipping forward. And then finally, if you want, you can use the mini electrodes and sweep it around the chamber. And I'll just do this quickly in the interest of time to create a rough electron-anatomical voltage map. So in this particular case, as you see, there was the transport ablation time was 6 minutes and 30 seconds. The left atrial dwell time, 14 minutes, and fluoro time was quite low. I should note this was part of a first-in-human series, and there's a publication from 3 centers, Mount Homolka Hospital, ICAM, and Vilnius University Hospital. This first-in-human series is published now in Europace. I'll just show you the top-line results, which are the 1-year freedom from atrial arrhythmias was 82% for the full cohort. There were no major adverse events as defined by the protocol. If we did durability testing, per vein basis, per patient basis, using the final pulse-free waveform, which was the best waveform that we had, 99% durability on a per vein basis, 96% on a per patient basis. That was a total of 26 patients. And here you see a post-ablation map and a remap voltage map. So our experience with this catheter is that it seems to be safe and efficient. And certainly we need to prove the safety, durability, and efficacy in larger studies and, of course, eventually in clinical practice. We should note that the procedures were all performed under general anesthesia. It's unclear whether or not we could use deep sedation. This is monopolar delivery of energy. Of course, other interesting questions, could we create other lesion sets like posterior LA ablation? Could we create a CTI lesion? You probably couldn't use the whole lattice because it's too big, but perhaps you could use one of the leaves and create this. And these are all questions that we don't have the answers to yet. Thank you very much.
Thank you, Vivek. Now we go back to ECAM because in both EP rooms they are waiting to show us something. Maybe are approaching to the end of their cases, and finally all the remaining time will be devoted to Homolka. So Predrag is probably first.
Yeah, do you hear us?
Yes.
Yes. Okay, I think we finished the procedure. We can only wrap up what we've done. So after a few applications on the proximal Bachmann bundle, we saw a slight change of the tachycardia. So we performed the entrainment from the proximal CS. Can we show that? It's on the right screen. I don't know if you, yes, here, and it was perfect. So we went to the CTI. Let's show the entrainment from the CTI. And it was also good. So we decided to ablate the CTI, and the tachycardia terminated here on the CTI. And can we show the termination? Okay, this is a termination of tachycardia. And can we see the pacing from lateral and septal part of the line? Just to show the block. Okay, so here you see that we have a separation of signals like 150 milliseconds. And can we show the pacing from the other side? Yes. So we have a bidirectional block on the CTI. And we try now to induce. Can we show inducibility? We usually use very aggressive incremental pacing from different sides of the left and atrium, and we could not induce anything. We came back to the left atrium just to check that we don't have a block on the anterior wall, because and I think we don't have to finish the whole anterior wall because conduction is okay and the arrhythmia was not micro-reentrant, probably, but only some micro-reentrant from the proximal anterior wall. So I think this is all. If you have any questions.
Did you check pulmonary veins?
Yeah, we can check it one more time. We check it, obviously, but let's check one more time. So we are in this, in the common trunk. Let's space from here, from FA to 3, like 15 milliamps.
What is interesting, there were two arrhythmias, one micro-reentrant from anterior wall, the second one was typical flutter, and both had almost the same cycle length. So there was no clear conversion from one to the other, but probably not in terms of cycle length. But I have seen some organization or different activation sequence in coronary sinus when it happened.
Yes.
It was not.
It was slight.
It was
change,
still
but
septolateral activation.
Yes.
It was still septolateral activation, but there was some small, like tiny difference of appearance of CS potentials.
So okay, do you have any other questions?
Yeah, there is one last one.
Yeah. Yes, I'm listening.
After last look at it again. After so thorough ablation in the anterior line, and I mean not in this case because as we heard, the anterior line was not completed, but there are many cases when you can see not always intentional, so I would say unintentional. Appendage block. Complete block of the not block, but isolation of the appendage. What do you think about this, and how do you treat these patients? Because when we do these kinds of ablations with many applications, unfortunately, it can happen many times.
Yeah, actually, we saw in few cases complete appendage isolation, but those were usually repeated ablations. So patients were after extensive ablations. So yes, in a case that you isolate the appendage, you need to close it, definitely, because the risk of stroke is significantly increased. So, and I think we have a few cases with isolation that we had to close the appendage after the procedure.
Thank you.
But we try to avoid it.
Yeah, of course.
Of course, yes, but
okay.
All right, so yeah, one more.
We are finished. Yeah.
Great case. Thank you so much. One question: how many total lesions did we give, and do you give this patient some, hydration stuff to prevent for any hemolysis?
We have only, I say only, 72 applications, so it's not too much, but we know that hemolysis is unavoidable. So for this patient, this procedure is afternoon, so we will probably give him hydration after this procedure.
Great work. Thank you.
So if there are no other questions from the audience, thank you again and congratulations. And we will move to the other room in ECAM just now. Yeah, I see you already.
Okay. So before we departed from your transmission, we did this mitral isthmus. There is a permanent block. And this is remap, so you see it's violet behind this line.
Can we go AP?
We finished that line posteriorly. We did one lesion in front of right superior vein where there was some small signal. And then we induced some tachycardia, which looked like flutter.
Can we go to Pruka?
We could not complete map because because it terminated and we cannot induce it anymore. So we are now on the right side, and we would like to show you in live CTI ablation with RF. So we are.
Can we go a fair map, the right atrium?
And we did, in the meantime, very brief map of right atrium, as you can see here. So I'm more lateral now, so I can correct a little bit. But you see that the map is very nice. And we are now sitting at the hinge of the tricuspid valve.
Can we show the intracardiac echo?
Intracardiac echo shows clearly where is the catheter. It's very stable position again. You see?
It's quite long isthmus.
It's a bit lazy isthmus, but very long and very straight. So I believe that we will need more than 3 applications to block. But let's start in this area. Okay? Let's go.
So we will use RF. Now we move a little bit.
Move.
Just slowly. Go.
Stop. It slipped away. Okay.
Let me delete that.
Yeah, we do.
Okay. Go.
There is a question, what are the parameters for RF? Peter, do you hear us? There is a question, what are the parameters for RF ablation here?
Go here. We don't have any voice from the conference.
Yeah, so can you hear me just now?
Ablation parameters are just
they are preset.
They are preset for the RF high power short duration. So there are 5 seconds of RF applications per side. We just sequentially moving, as you can see. So
it's here similar like pulse field. You have to preset. Everything is tested before, so there is no way to change things.
Okay. So it's again temperature control, and there's a lot of energy going in. But as the surface is much larger, so hopefully the risk of steam pop is very low. Actually, I haven't seen any steam pop with this technology.
There is a block. On the reach now.
Yes, so if you just one more.
Almost there was block.
If not, we can remap after the line and see what's the. This remap, quickly remap. Okay, just do one more here.
We are really sitting in almost in IVC. Yeah.
And we go remap. Okay. So go remap just the lateral part of the line. Okay, so this is it's much later now. So it took within the live transmission 1 minute to block the isthmus.
If it should be shorter, it would be like 15-20 seconds.
You don't impress many people by ablating flutter line, but
I'm impressed.
The speed that you can do it is impressive. So you can have the idea about the power of the system and the versatility with using both RF and pulse field. The RF is doing kind of durable lesions for sure. The pulse field with the latest kind of pulse waveform, it's also very durable. The problem with the RF is if it's blocked, it stays blocked. With the pulse field, it's we are really a bit kind of cautious because acutely the signals go away, but long term it might be still.
So you saw probably very fastest ablation of CTI with RF, which is really amazing.
Questions, comments?
Questions, comments?
I have a question about surrogate of efficacy of lesions for RF and for PFA. So it's for RF we have some kind of impedance drop, signals and ice, like whitening on ice. What do we have for PFA
we have tested in studies, in proper studies where there was a remapping. So you have tested pulse configuration. So that's why you cannot say pulse field works, pulse field doesn't work. For every platform you have to have preset data confirmed by remapping that it really can do like 100% almost isolation of the pulmonary veins. And then you just work with this pulse, because you have no time and no way to change hundreds of parameters which can be changed for a pulse field. This is tremendously different from cryo or from RF. So remember that you don't need to think. You just do like trained dog. You do this isolation, you do a line. There is nothing to be discussed about pulse configuration. Either you believe the data from the study and you do it, or you have to do some study yourself to test it. But this is how we spent last 6 years almost to do studies with Afera, and we remapped. They changed the pulse configuration and characteristics of the pulse. We remapped again in the second series and third series, and there was a study which was published by Vivek, and the same was for Farapulse. And if any company does not have this remapping data, it's very difficult to believe that's optimal pulse field configuration, because you have to wait maybe for long-term efficacy. But acutely, you can always isolate the veins. You can always do the line acutely. But without remapping, it is very difficult to believe that it does what it should do in long term, let's say durability of lesion, durability of lines, etc. So this is tremendous difference in philosophy, because we were used to change duration, we were used to change irrigation flow and maybe energy, but or temperature, if it was temperature control, but that's easy. But here it's very complex, and that's why you have to work with pre-tested values, which are preset in the system.
One last question. Number of application. Is it number of application of PFA energy for some region of left atrium or right atrium? Is it predisposed, or it could be changed? So, and if you apply more application, what this depends on?
What do you ask? The last sentence? What is?
So anyway, we have like different number of application for PFA. It's not the exact number. What is influence? What is your decision when you make it more or less?
No, obviously you want to see the effect, but this was done with RF. So here we just did some overlapping lesions to block the isthmus. When we used this RF or pulse field for mitral isthmus, we applied a couple of lesions just to be on safe side and block the isthmus. So, I mean, if you are working with a number of lesions like 10, 15, I think it doesn't matter. You should not do like 150 lesions, because then you have a risk of hemolysis. You may have some other adverse events. So.
Just one comment to the mitral isthmus, that we use both RF and a pulse field. Just remember, this was already previously ablated mitral isthmus. So there was a pre-existing scar, and if we believe that the pulse field have a better penetration through the scar, may explain why the RF had a problem and the pulse field was effective. But obviously, I'm pretty sure that this will stay blocked because there was clear.
You have to remember also that you have almost 1 centimeter big diameter of the electrode, so you create 1 centimeter, at least 1 centimeter wide lesion. So it's like motorway across the isthmus, you know, whether it's a mitral highway, whether it's mitral tricuspid isthmus. So it's completely different from solid tip technology.
So you had two types.
Just to summarize, we finished the box. Just one comment about the box. I was the one to do the posterior wall ablation using Farapulse. It was our early experience that time. Hopefully we got better, because I haven't seen any reconnection of the box. This is my first, to be honest. Generally, because the footprint of the Farawave is such a large, so you have to really skip part of the line to really have a channel and leave the channel if you decide to do the box. But it happened in this case, so it's a learning for me just to be careful at the right-sided veins, not to skip any single place. We did finish the mitral isthmus line, as you hopefully see, and you saw the remap. And we have some residual induction, and we did the CTI, which was very fast. So generally you move, I believe the strategy for these patients with persistent AF should be more like do the preset of lesions rather than to map every single arrhythmia, because then it takes forever. But if we know that the posterior wall is the isthmus one and the second isthmus and the veins are probably needed to somehow stabilize or somehow compartmentalize the atrium, this is the way to go and see what's left.
Basically, you are reproducing MACE procedure. That would be for future pragmatic set of lesions. And if it works like we believe it works, I doubt that people will go anymore for surgery. I'm sorry to say that, but I think that would be future. So if there is no any other question, we probably will finish the case. If you are okay with that.
Yes, there are no more questions, and thank you again. Congrats, and
no question.
See you later.
Thank you very much. On behalf of all team here, because we all work together.
Now we are switching to Homolka, and the rest of the session is devoted to Homolka only, because all 2 cases in ICAM are already closed. And so they have more than 2 hours and a half to present their cases.
Let's go 1 hour.
Hi everyone, can you hear me?
Yeah, all right.
Welcome back to Homolka Hospital. This is the case number 3. And we're going to show you the Omni Pulse case with a paroxysmal AFib patient. The patient is 67 years old female, and as written here, normal ejection fraction, LAD 36 millimeter on TTE, hypertension, and anticoagulation. Next, please. And the last AFib was documented March. Next slide, please. March this year. This is the AFib ECG. And quickly show the feature of the product. Okay, go to the next, please.
All right. So hello, everybody. I hope you can hear me. We have a few slides to show you the catheter we'll be using today, which is the OmniPulse catheter, part of the OmniPulse platform, which is a large footprint focal PFA catheter. If you look on the slide, you see that it's an integrated PFA catheter integrated in the 3D mapping system. And if we can zoom in on the catheter for a second here, we have a non-sterile demo here. If you can zoom in here, you can see it's a catheter with 6 splines that is deflectable, that behaves like you would expect a steerable catheter, to behave. And you'll see that the tip is designed to be atraumatic. If we push it, you'll see that it bends nicely, it compresses well. There we go. The catheter has a internal reference electrode for unipolar EGM filtering, which significantly improves the signal quality, of course. And it also has a force sensing element, which will give us force indication as we're used to from the conventional small tip catheter. You'll see it in a second in the case. If we can go back to the slide, please. So we can go to the next slide just to show you a few features of the software platform before we go to the case. So as mentioned, the catheter has electrodes which can be used to do normal electroanatomical mapping. It has a contact force sensor, as mentioned, which can be used to serve as a filter to make the map width. And of particular note is that the system integrates an ablation index, as has been developed for focal RF ablation, an ablation index based on preclinical data that we'll see in a second. And you will see in the case that the system is designed to predict the ablation index that will be generated after 12 applications, because we will do a maximum of 12 PFA applications per position. And given a particular position and given a particular contact force, the system will predict what the ablation index will be. And of course, if we do not achieve the desired target, 400 posterior, 550 anterior, we will try to improve that before going on to the ablation. I think that's the most important part for the catheter, and we can go to the next slide. This is the last thing we want to show, is just the development and validation of the ablation index data, where you can see, first of all, as universally appreciated, that contact force correlates with lesion depth, and you can also appreciate that a sizable amount of contact force is necessary to make good lesions. On the left, you see the data for development of the ablation index. On the right, you see a validation study, preclinical validation study, showing a nice correlation between expected lesion depth and observed lesion depth. The last thing to keep in mind is, as we go to the case, is that the contact force you will see during the case is a contact force which is measured, but should not in your head be translated to contact force as you are used to seeing with small footprint catheters. As a rule of thumb, you can say that the physical effect of the contact force that you will see should be divided by factor 4 to translate what the effect would be for a focal catheter. So if you see contact forces of 20 or even exceeding 30 grams with this catheter, it does not imply the perforation risk you might expect with a catheter with a much smaller footprint, which is a simple result of physics, of course. Okay, and then we can go to the case. So I'll show you briefly what the catheter looks like on the ultrasound. Like Vivek said, ice is nice. I couldn't agree more. If only we had the budget. But this is what the catheter looks like. It's floating in the left atrium, and I'll show you briefly the appearance on fluoroscopy as well on X-ray. And so we want to start by building a very basic geometry to show you how the process works. We can start that now. You can start the mapping. And just to illustrate you that it behaves as you would expect, it's fairly simple to manipulate to the veins. There we go. You can follow it on the ice. Thank you very much, Peter. I can deflect using the catheter or using the sheet or both. You can see the EGM quality on the right half of the Carto screen. You can see the catheter EGMs in white. And you can see that it's fairly easy to manipulate the catheter in all 4 veins. Now, this is of course not the highlight of this case. We just thought you'd be interested in seeing how it behaves, how it acquires points, and to show you that it does indeed perform as you might expect if you look at the design. But the point of this case is to show you the ablation, of course. So we did actually make a complete map. Let's switch to that now. We made a complete map 5 minutes ago before we came online. And what we'd like to do now is show you what the actual ablation looks like. Right, and before we actually do anything to our patient, I should mention everything you are seeing is part of an investigational protocol. This catheter has not yet been CE marked. This catheter is under clinical evaluation in the EU and is therefore not approved for commercial use. So here you can see catheter in the posterior wall position. Maybe, Peter, you can give us an eyes view if we can find it. And you can see that with the contact force we have here, 25, 28, you can see the predicted PF index, which is our ablation index, which far exceeds what we need. So this is good. This is how we like it. So if we start the ablation here, we expect to reach our target value of 400 before 12 applications. And we will be able to stop the application. You can also nicely see on the ICE image the deformation of the catheter. You can see how the echo image confirms contact because we are deforming the shape of the catheter. And I think we're ready for our first application here. Have a look at the EGMs on the carto before the application, and let's start here. Off we go. Please do. You see the real-time ablation index on the bottom there. We've reached 350 now, 370, 400, and one more for good measure, and there we are. So that's application number 1, and you can see that we've eliminated the near-field component of the EGM. Target interlesion distance on the posterior wall is 4.5 millimeters. Tag size is 9 on the carto, so the tag should overlap like this. And again, here we have a good predicted lesion index, so we can continue with lesion number 2. So as we go along, the process is going to be like standardized PVI should be, fairly predictable, fairly anatomical, fairly protocol-driven. I'm happy to take questions. I'm sure Peter can comment to what we are doing if there's any observation from the audience. Meanwhile, I will continue making my circle on the left side at pulmonary veins.
Actually, it's very important to get overlap of the lesions. Actually, it's predictable, but it's like we are not going more than like over 3 millimeters. And I think that, as Tom stated, that it's predictable of the force is like very, very important. Actually, we can map and we can use any feature like filtering the force, so we can create the map even based on the contact force. Which is important because we are able to not deviate the anatomy.
No.
And here's again very nice position. So as another technology the guys already showed now. So this Omni Pulse catheter is very nicely visible on ice, and we have very nice control. The question is only one that you can see on the fluoro, the sheeting. The sheet shouldn't be so close to the catheter because the magnetic sensor is there. So you need to be a little bit farther out of the catheter tip or the ball. And the question is that you can really appreciate using the deflection of the cutter itself and or helping you with the Oscar. Oh, we are using Oscar here, Oscar sheet as well. And the contact is fantastic in here. And you know that it's like proximal patients. So we hope that we will, after the study, will expand the application for more complex atrial fibrillation patients. And Tom is really taking care about the placing of the tip. So it's like very nice force and very nice overlap of the lesions. So I think it's...
There's one more important thing to note, I think, if you're used to looking at these tags and the ablation indices. One limitation, I think, of the platform, because it's investigational, it does not have stability features. It does not compensate for respiration at this time. So the position of the tag is not, you need to pay a little bit more attention, which is why I sometimes take a few more seconds to judge my position. You need to take a little bit more time to make sure your lesion is where you want it to be.
But I hope that the guys can analyze the stability feature in a retrospective way. Can you just a little bit? Okay. Oh no. So Thomas, boss.
Yes, let's do this posterior gap. I'm getting some. I'm getting some feedback from Helen here that I'm not doing a good job. So.
I fulfill the one position, right?
Let's rotate a little bit, Helen, so I can appreciate that I'm where I want to be. Yep, okay. And then let's continue anterior, yes. You see, I can use the contact force vector here as we're used to from the focal catheter, just finding my contact on the ridge, making it point in the direction I want to point, making sure I have good contact, and then we go ahead. Can we see the catheter once more on the ice, please? So yes. The ice is, of course, incredibly valuable in assessing the depth of the ablation.
Yeah.
Okay.
Yeah, underneath the inferior vein.
Yeah. Here always a position where very high contact is not easy to generate unless you go a bit in the vein, and this is of course one of the fantastic aspects of pulsed field ablation. There is no concern whatsoever with depth of ablation.
Actually, we need to add that the procedure is done in general anesthesia, and of course we need to suspect then after the study when this technology could be used, like in some sedated patients, right? It's a very nice positioning here.
One more thing that is worth mentioning is that the patient received prophylactic dose of atropine 1 milligram to avoid vagal responses, which can sometimes be pronounced with PFA technology. Not necessarily dangerous under general anesthesia, but sometimes can lead to, for example, patient motion.
Good job. Oh, fantastic.
Oops. Let's do this position first. Nice. It was nice, I agree. I liked it
see
too.
that here. It's nice. Good.
Yes. Again, nice contact. And then let's put one in between. So now I leave it a bit to the chairs if you want to stay with us or introduce the case in the other room and then come back. Everything works for us.
Actually, I think that they are ready to show something. So
everything works.
If you don't mind.
Yeah, definitely it's up to you. So if you know that there is something interesting,
okay, so happy. So you can switch to the other lab because they really want to show you.
This is pretty comfortable, so you can stay as long as you want.
Go live now. Slide is there.
Great.
Okay. So hello from Homolka again from the room.
Hello.
For case number 4. So I would like to introduce Nandor Chandor and for the patient with QDOT system ablation for paroxysmal AFib with easy lady with 65 years old, preserved ejection fraction, normal LA, slim lady, even small beta blockers, about 5 years history of paroxysmal AFib. So nothing very, very special here, very borderline CHA2DS2-VASc score 2. So let's move on to this is AFib recording from paroxysmal AFib. It's about the episodes, about hours, several times a year, not very frequent. So now we are in our lab back, and I would put the voice to Nandor.
Hey. Hello everyone, good afternoon. So I quickly want to say a few words about the setup that we have. It's groin punctures on the left and both on the right, 2 punctures each side. We have an ICE, we have a CS catheter, an SL0, which was used for the transeptal puncture, and an Agilis sheath of S-curve, which is very important for me because basically I use the steerable sheath for catheter navigation. I also believe it's very important because this way, throughout the whole circle, your lesions will be more like in a parallel catheter tissue orientation and not perpendicular, and it was shown that these lesions are somewhat wider. So my idea for
this case that we discussed here would be to go all around the circle with using the Q mode plus, meaning 90 watts 4 seconds. Alternative approach that many use is that they do the posterior wall with the 90 watts and the anterior wall with ablation index guidance to get larger lesions in that area. Sometimes if I see that the tissue is very thick or we have a very overweight patient, which is usually pre-selected at the outpatient clinic, so BMI above 40 does not really occur on the table in my lab. So for those patients, we may do a few applications with ablation index guidance to use a higher value, or alternatively, what we can also use is to deliver double application with 90 watts at the same spot. So for those who are not that familiar with the Q dot, I just want to say like 2 minutes about how it works. There are two modes. The normal Q mode is used for up to 50 watts, and it's a power controlled mode where the main parameter, the main thing that is modulated is the irrigation fluid speed, and then if the target temperature is reached, then in that part the power is going to be modulated down, so it's more like playing with the irrigation a lot. However, the Q mode plus, we have the irrigation rate of 2 and 8 cc's per minute, and then the system plays within this 4 seconds of application with the power regulation. Whenever the target temperature is met, it is reached, the power will be modulated down, and this may happen 2-3 times during one application whenever it is necessary. I believe that the catheter stability, parallel catheter orientation in many places is of high importance, and also the interlesion distance. So we will use an intertac distance of less than 5 millimeters anteriorly and something around 5 millimeters on the posterior wall. That would be the plan. And we did not start the ablation yet. Any questions or comments from the lecture room?
There are none, so I think you may start.
I did. Yeah, so it's a pretty healthy left atrium. You can go to the ridge view, please, Peter. I always use the distance measurement tool in order to see how far I am from my last application, and I will also ask Peter to show me always the distances from my very last application, please. Okay, and make the map a bit more transparent, because this way I will see my ablation points. That's quite important. Okay, 6 millimeters, too much. And what I usually do is, before checking whether I have first pass isolation or not, I usually like to ask our support specialist to go through the points and double check whether we have all the interlesion distances within our target value. So I think that this was a bit more far away than I wanted to, so I will ablate one more in between. Okay. Sometimes tricky to stay there. Yeah, I also lost my position during the application, so I will go there. And one other thing that's important for me when doing the procedure with 90 watts, where we don't have a concrete lesion feedback like the ablation index or lesion size index, is that we need to be honest with ourselves. So if I was dislocated, especially on the anterior wall, I would go for another application, or even more here in the carina, which is a very likely place of reconnection for some more ablations, because usually that's a thick tissue. I would not do that on the posterior wall, obviously. Can you make it a bit more transparent, please, Peter? Yeah. Okay. And remove the points. Those are just... Remove the points. I don't need the map points. Thanks. And my experience is that, similarly to Tom the Potter, who also said he is a 10-gram guy, I also prefer not to use extreme contact forces. Usually, if the catheter position is stable, especially with high power, I believe that something around 10 gram is enough for the ablation. You may see that many times I have like 6 to 8 grams when I step on the pedal, but then I turn my catheter a little bit more, and then I will reach the 10 to something grams during the application. That's the carina. I don't like the carina, so I will ablate a bit more here. Obviously, the main reasons for not having first pass isolation is that there may be gaps at the carina region, both on the left and the right side. Is it 6 millimeters from the last point, really? Okay, no, it's not.
Nandor, can you hear me?
Yes, definitely.
Please, can you show also ice image? Some smaller screen.
We'll do that
because we see only.
I can then continue the ablation.
Yeah, we have it down. It's there.
We are using ice.
Yeah, but can we see the ice image as well? Because we see only Carto screen. Yes.
Okay.
And if I understood well, your target interlesion distance anteriorly is less or equal 5 millimeters.
Less than 5. So at the end of the day, we will count something about that. But my experience is that if I use a target value of less than 5, so I check the circle at the end, and everything that is below 5, I put one more point in between, we will end up with an intertech distance of around 3 on the average.
All right, so including posterior wall.
No. For the posterior wall, it's something around 5. So on the posterior wall, obviously, if I have like 5.2, 5.5, I may accept it depending on the. Can we go PA? Depending on the contact force that I had during the application. We also consider sometimes the signal attenuation and such things. Yeah, please show me a PA where we see the veins from the posterior. This is just a simple PA. Yes, thank you. Thank you. This should be the bottom of the vein. Yeah. So it's quite usual with the octary that it overmaps. So in these cases, obviously, the support needs to adjust the map. Is it okay if I come somewhere here, upwards, or do you want me to go wider?
Well, it depends on you. I think maybe a little wider is better here.
A bit wider. Okay.
Just tiny scar there, but not too much.
Okay.
Maybe
Good.
The narrow corridor is dangerous for flowers.
Some transparency, please. So here, as we are in a region that may be close to the esophagus, I will. I won't repeat the application, and I won't put another application here. So, considering also the thermal latency, which means that after the application, it takes like like 14, 15 seconds for the tissue to get below 50 degrees. Whenever we are in the posterior, we can also play with jumping from one spot to the other and doing the ablation in a non-contiguous way, and this way the chance of damaging the esophagus is smaller. Okay, so I will continue here. Okay.
Yeah, it's now cool. So yeah.
For checking the stability of the catheter, I also use those 3 brackets that you see on Carto. If it's like the guidelines, if you have all 3 brackets or 3 squares blue, it's a class 1 indication for me to deliver the energy. If it's 2 brackets, then it's 2A. If it's only 1, then maybe we should consider repositioning the catheter. This was the region where we were close to the esophagus, so for this reason I stopped even before finishing all the 4 seconds. Okay. All right, so I will go upwards. Can you show me the distance from that last point, please? Thanks. Sorry? No, wait 1 more second. I want to put 1 more here in between because we are now far away from the dangerous region. Okay, now you can go and clear your view. Please measure my distance from the closest point. Thank you. Okay, now please check my interlesion distances now. I don't see a point here. I will put 1 more. Okay, there was. Maybe there was in the middle, in the back. Yeah, you can move now.
So, okay, Nandor, do you prefer to have octaray somewhere in different vein, just not to be interfering with ablation catheter, or
yes, the main intention is so that we have the octaray on the right side. So with that it's not in the way, basically. Yeah. Yeah, I have to put a few more lesions here, I guess. Yeah. Yeah, here it jumps out. Can I see where the gap is here? Because I think there is one, or maybe 2. Now it looks not so bad. maybe one more here because I see a huge visual gap here. Okay, and after that, we have, I mean, on the posterior there were some points where it was 5 point something, but I don't really care because that was close to the esophagus, so that's, how much is that? 6.1? Maybe if I was home, I would deliver one more there.
Yeah, you can, for
okay.
Sure. We checked circuit catheter here.
Can you measure my real-time distance from here? Okay, it's 7, too much. 2 is good. Contact force is not too high. Okay. Okay, good. So, yeah.
Maybe show the octave point catheter with the octave king.
So I should put them. Yeah, let's check it.
Maybe.
Yeah, let's check it now.
If you are happy. It looks good, yeah.
Yeah. So we'll see what we did until now.
Peter's mouth will be just this. Oh, it's okay. No, it's fine. So it looks good, yeah.
Seems good for my eyes.
Rotate.
Okay, so we'll move to the other side.
Right, maybe inferior.
Check the inferior too. But it's one circle, I expect it to be good.
Actually, your eyes.
Hi, one question, could you paste from the vein?
Yeah, because signals are difficult to see from octave, so we would like the question from audience is to check, do the pace map from the vein or...
We can paste. We can paste.
From mapping catheter, ablation catheter.
Yeah, sure. I will put the ablation catheter so that you will see that we also have contact. Okay, paste from the ablation catheter, from the ablation distal, please. Right from here.
Yeah, just the artifacts on octave catheter now.
Yeah, there are some artifacts, yeah. Oh shit. So I have 0 grams, now it's 7 grams. Yeah, it's not capturing. We have entrance block, we see it nicely here in the lab. Okay. You can stop pacing, yeah?
You can go for
okay.
If you like.
So we will go for the right side, if you're okay with that.
Já bych to býval obešel.
No problem, I think you can.
Yeah,
go.
We can continue.
For sure.
Maybe you can go to the other room, as you said, as we are finished with the left side, so...
It's quick, maybe we can do it. Maybe you can go.
Yeah, okay, if we can go on, okay.
Nobody
it's also good one.
It depends.
Show me the interior.
Let's move. Guys, go. Szczepane!
Hello again. So we've waited a bit to show you the end of our right side ablation. We're anterior here. If you look at the patient, you'll see phrenic contraction here, which is quite typical in this position with PF application, which is of no concern. We have never seen damage to the phrenic nerve. We've seen reaction, but never damage. And one of the interesting things is that even with GA and paralytics, it's extremely hard to completely eliminate the phrenic nerve. Well, actually, I'm saying phrenic nerve, but I'm not sure if it's direct muscle contraction of the diaphragm or stimulation of the phrenic nerve. But at any rate, it's unusual to see no reaction at all, to be honest, even with strong paralytics. You see we're moving over to the posterior side here. After this application, we'll flip the view. I think we need to do 1 or 2 more spots on the roof posterior, and then we should be done. So let's do that, yes. There we go. As Peter said, I need to keep the sheet a little bit away here from the catheter in this position, well, in all positions, to have the force indication. And you can see that sometimes with the phrenic nerve contraction, the catheter tends to move slightly into the vein and then come back to its position. Again, of no concern. And here we can do a last posterior point. Okay, so I think let's have a visual look, but I think our circle looks nice on the right side as well. Let's see if we can identify gaps or spots we don't like. No. So I think it should be good. So we'll remap using the same catheter. Let's go to PA and start pacing from the CS. As we remap, feel free to ask questions or point stuff out you'd like us to do. Let's start the CS spacing and let's start the mapping process. We can pace a bit faster, yeah, why not? We can pace, yeah, okay. Okay, you can see both veins on the right side are clearly isolated, complete lack of voltage. We'll map with a dedicated multi-spline catheter later as part of the study protocol. But as you can see, this catheter itself is perfectly adequate to judge the isolation with. If it would be a routine case, I would use a single catheter workflow. Of course, I would not need a dedicated catheter. I'd take this one. You can nicely appreciate the level of ablation, the level of isolation, which correlates nicely with the position of the ablation points. And also the left side is looking very promising. We didn't look yet. It's I'm discovering together with you. Okay, left side is excellent. What you're seeing here is what is called the crowd wisdom map. It's a new feature with this catheter, where not every individual point is annotated on its own. It is using the information from its neighboring points to come to a consensus value, due to the fact that it's easy to take so many points, of course. So sometimes you can compare it with conventional maps and see that the small little islands of illogical low voltage are eliminated. In this case, I don't expect to see much difference. Of course, it's a paroxysmal AFib case, so there's only healthy voltage and ablated tissue. But in cases of fibrosis, I'm sure it can offer added value. Okay, let's go AP, but actually there's not much need. So here's the catheter in the appendage. Should be nice and healthy. There we go. And let's go to the roof. we go. Okay, so clearly our veins are isolated, and what I suggest we do now is we change our ablation catheter. I'm just going to have a quick look at our support staff, make sure I didn't forget some study-related activity, so they don't yell at me after we're gone. Looks good. And then we're going to finish by making a validation map with the penta-ray catheter, as mentioned, as part of the study protocol, not for specific clinical reasons. All right. As Vivek already mentioned, air management and bubble avoidance is extremely important with all of these technologies. All these catheters are fairly bulky, big sheets. Air embolism happens before you know it, and it's good practice to always aspirate and double check. So we'll connect the penta-ray now. It's flushed already. No. Okay, and then let's introduce it here. There we go. Thank you. I also want to point out something on the eyes, which is something of interest to me lately. So we've all started calling these things we see on the eyes during PFA application microbubbles or air bubbles. I'm not sure we should. I'm interested in hearing everybody's opinion, but as you clearly see here now, we're simply flushing the catheter, and obviously we see echo-dense phenomena, but an echo-dense phenomenon is not synonymous with an air bubble, and I'm not sure if we should keep calling these phenomena we see during PFA application. I'm not sure if we should universally keep calling them air bubbles. Interested in hearing the opinion of the audience and the chairs. Let's start pacing and do the remap. We still need TPI. Forgot there's such a thing as TPI. There we go. But we can already take a manual point as well. Yes, okay, we got the TPI. It's on. Are we getting any audience feedback? It's awfully silent in my headset. Maybe no one has questions. It's possible.
There are no questions, I'm sorry.
Okay, no problem. Then please keep watching. What do you think about this ice stuff? I mean, you guys in Prague, you have an extremely large ice experience. What do you think about these phenomena we see during PF application?
There are one question. Yeah.
Excuse me, a small question for the audience. When you're making a map, density of the map with a penta-ray differs from that new catheter, or not? Thank you.
So we can compare the maps in a second. What I can tell you from preliminary experience is that the level of isolation seems to be a little bit wider on the ablation catheter, the map that we just made, compared to the penta-ray map that we're going to make now. In terms of values for voltage, no. In terms for values for timing, absolutely not. For an LAT map, they are equivalent. I would argue the Omni pulse catheter is probably better still due to its better filtering than the penta-ray. Values of voltages, we have not looked at that too much specifically. And as I said, the level of isolation tends to be, I don't know if you saw when we made the Omni map just a second ago, it was a little bit wider than where the dots indicate. And here you see with the penta-ray, it seems to be exactly under the dot. So clearly the veins are isolated, no discussion. I'm spending some time to make the map look good, to make sure we have nice data. But there is no discussion that we have first pass isolation. Let's get some points here. And then after that, let's move along a bit. And one of the last things we'll do, maybe you can stay online for that, is do an adenosine challenge, also as part of the study protocol, to check for dormant conduction.
Okay.
As far as we know, adenosine works equally well to identify dormant conduction in PF as in RF and cryo. And we have indeed observed some acute reconnections. So we can go ahead with that. We're preparing the adenosine and we'll check for dormant conduction. Shall we give it on the CS sheet?
Sure, yes. Oh, the nurses.
Oh, the nurse will do it. That's perfect. Okay, adenosine 12 milligrams whenever you're ready. Helen, maybe you can show us some monitor screen somewhere. It's GA, I'm not too concerned. So we don't have a pacing catheter is the comment, but in GA, I mean, I've never seen a patient not recover after adenosine. Let's give 12 milligrams. Yes, normally, yes. Okay, let's give the bolus. Helen, show us a monitor screen on the bottom somewhere so we can see the running. Voila, okay, let's see. Put it on 50 millimeters, please, 50. Okay, there's the block just in time. And now we wait. This is where I regret not having a pacing catheter. There we go. We have experience with extremely high doses of adenosine. For our rotation angio workflow, we used to give 100 milligram bolus without any issue. It's been well studied. It's perfectly safe. Of course, without GA, this would cause significant patient discomfort. Okay, this one is good for the next vein. I think we can give 6 milligrams. The patient is clearly sensitive enough. Can we do the next bolus, 6 milligrams, please? Can we do 6 milligrams? Yes. Okay. And then we 6 milligram bolus is going in, and we will need it 2 times more. So now we wait until the block, and then okay, here is the block for the LIPV. Very sensitive patient, clearly. Okay, recovers. Here is the RSPV. Whenever you're ready, you can give the next 6 milligrams. And I suppose if we hurry a bit, we can do the RIPV in the same injection, because the block always lasts long. So, saves us 1 injection. There we go. Okay. No reconnection. And here's inferior.
So you are using 6 milligrams per vein, yes?
It depends a bit. We gave 12 for the first vein, but then we observed that the patient is very sensitive. It was quite a long AV block, so we lower to 6, but there is no pre-specified dose. The dose needed to generate transient AV block, or even transient PR prolongation is okay. We can give once more 6 milligrams and then we're done. So as mentioned, under GA, it's really not an issue. The only potential concern can be some bronchospasm. And then our case is finished, so if you have any other question, now's the time.
No questions. There is one.
Tom, nice case. Darren here from New Zealand. Just interested in your thoughts as to, in the end, what the differences between this catheter and the Affera catheter might offer. Obviously, one being monopolar. If I understand it correctly, this is a bipolar application of PFA. It looks from your voltage map that you don't have much effect off target. In other words, the voltage on the posterior wall is intact, which is not always the case, I think, with Affera, with a WACA lesion set. Presumably that's partly a difference between monopolar and bipolar delivery, but yeah, just interested in your thoughts as to what the key differences might end up being, understanding that it's still pretty early experience.
Yeah, so that's an excellent question, and from a clinical perspective, impossible to answer, of course, but looking at the catheters and the designs, I think the obvious differences are, one is PFA only, this one. Affera is PFA RF hybrid. One has contact force sensing, this one. Affera does not. I think two things will be important to answer your question. How will we use this in clinical practice? One, obviously, the clinical outcomes. No doubt this will drive the success of either product. Two, I think, is the integration with the existing ecosystem for 3D mapping and ablation. And to be honest, there I can't say I have a lot of experience with the Affera platform. I do have extensive experience with CAR2, obviously, for all kinds of mapping of AFib, AT, and ventricular arrhythmias. And I think the successful integration of any catheter in such a platform also drives its success, as we've sometimes seen with new technologies. If you have a platform that may be very elegant or maybe superior in one aspect, but as an integrated system lacks certain things, is less nice to have than something you're well accustomed to. But that's a long answer to tell you I don't know, obviously. I don't know, but the differences from a technical perspective I think I covered. And while maybe you chew on that or have another question, we're going to pace the phrenic nerve, distal pacing on the CS, please, also as part of the protocol to document integrity of the phrenic nerve after ablation. So let's pace maximum output on the CS distal. There we go. Okay. Okay, that's clear. Yes, okay, that's very nice to mention. So one of the things Peter is mentioning is that this study, as many, you can stop pacing, as many of the PFA studies includes mandatory remapping for at least a subset of patients. And this patient is indeed included in that substudy. So in 3 months, he may undergo remapping to document durability of the isolation, which I think for these new PF technologies is important to understand the performance from a technological point of view, whether it translates to clinical benefit, yes or no, is then evaluated in the larger study, of course, but at least to understand the durability of the lesion, remapping seems to be almost universally applied in most of the studies I'm aware of. Anything else I forgot? So these I know you guys have 2 hours and a half for live cases, but you scheduled 2 very efficient technologies, so that's going to be an issue for your timing. I'm sure the high power case is also pretty well advanced if Nandor is doing as I think he's doing, so I don't think we'll need until 7:30. We're done, guys.
I think we can finish the case if you want, but
okay,
because there are no other questions.
All right, so thank you again, and probably we will see the last. The entry from the last running EP room. Hello.
So
hello everyone.
Welcome back with Nandor to get again finishing the procedure and introduce you, Nandor.
Yeah, so we are done with the 2 circles. We just checked it from the very first application until the very last one. It took 23 minutes to do the 2 circles, and right after that, like a few minutes after, 5 minutes later, we started to do a remap that you can appreciate on the carto. On the left side, you see the post-ablation map, and on the right side, you see the pre-ablation map, and you also see the lines. Can you please turn around so that the audience will see the lines both on the anterior and the posterior wall? Yeah, that's quite usual. Show me an RAO, please, or something like right lateral. As you see on the anterior carina, I did a few more applications, like 2 or 3, if I can recall it properly, that were a bit more inside. So I like that kind of triangle-shaped lesion set on the anterior carina, because in our remapping study we have learned that this is a very frequent site of reconnection, both with 50 and with 90 watts. Would you like us to pace the veins to see that we do not capture?
Yeah, you can do this, but we believe that PVs are isolated.
Okay, great. Then, I mean, we just did it a few minutes ago, so if it's not a must, then we will. Shall we do it? No, if you don't want to see that, then we don't. Then we are not forcing you to see that. So, any other questions or comment from the auditorium?
Probably not.
Yes, there is one.
Congratulations, very nice job. I have only one question. Is there any comparison in your study between the 50 watt and Q dot and the 90 watt Q dot plus circumferential ablations? Is it reliable to use the Q dot plus even anteriorly?
The question was whether what was the result of the remapping study that we did with the 3-month remap?
Yes,
yeah.
And
so,
if it was a difference between the Q dot, that is the 50 watt, and the Q dot plus.
Okay, thank you for the question. So the study, as I said, it was a prospective randomized one, and it was a non-inferiority design study. And what we choose to our primary endpoint is pulmonary vein reconnection, I mean on a per PV analysis. Because obviously this is something that you can do in case of invasive remapping. So we had 20 patients that were remapped in each group. So 20 in the 50 watts group and 20 in the 90 watts group that were remapped after 3 months. And what we saw, this means around 150 something pulmonary veins. And we saw 88 and 92% of durable pulmonary vein isolation in case of the 50 and 90 watts. I mean, numerically, that was a little bit higher in 90 watts, but there was no statistically significant difference. And the study was, and we also did the analysis for it, obviously, and the non-inferiority criteria with that were obviously met because it was even a bit higher, but the sample size was also enough to draw conclusions from that study. But as you see, we also did this case with 90 watts all over the circle, and we had nice first pass isolation on both sides. No touch-up applications were necessary, and yeah, we've been waiting for like 30 minutes with the left side and 15 minutes with the right side. So there is no acute reconnection. So we are happy.
Thank you very much. Thank you.
Maybe we can comment as well about the temperature in esophagus as well. There is the probe, circa probe inside, so you get only once the elevation of 39.4 degrees, so you can maybe see this red, a little bit less red dots, so there was little lower application, shorter, about 1 second shorter after this temperature rising. It was only once, so probably this is a safe, but still we can produce some elevation of temperature even with very short 4-second application. So still.
Definitely. So we were asked to use temperature probe now, which is not routine in our lab. We don't have it, but the patient is in a very mild sedation. So whenever the patient's feedback is that the patient feels pain, then we do pretty much the same that we did here, that we may shorten the application time from 4 millimeters. And one other thing, again, I want to stress, because it's very important for the 90 watts, you can use it for good things and you can avoid bad things with it, the thermal latency. So once your application is finished, there is I think 4 or 5 seconds when the intra-tissue temperature still rises more and more and more, and then comes back to the same level where it was when you finished your application. So there is about 5 seconds when the intra-tissue temperature goes even higher after stepping off the pedal. And it takes around 15 minutes to get below 50 degrees of Celsius. So you can use that to enlarge your anterior lesions. If you go like back, right after each other, you need to wait 4 seconds after the last after stepping off the ablation pedal, after stopping the application, because there is a mandatory pre and post irrigation. You cannot ablate faster or quicker than that. And on the posterior wall, if you had a temperature rise, you may continue your ablation line at another place that we did. You saw it live, I think, when we discontinued our lesions in right after each other. But I went up somewhere here to the upper part of the left pulmonary veins, and then came downwards. And then when I was close to the painful or temperature rise part, then we decrease the time of RF delivery.
Just can I have one more question? So
sure.
First of all, I would like to congratulate Nandor for this beautiful case, and congratulations. And I mean, taking into consideration that we could see that the time of the procedure was absolutely comparable or faster than some of the other very advanced technologies. Taking into consideration that we could see a very nice contiguous line, and actually congratulations also for this beautiful textbook, like I mean, mapping and ablation. I mean, the original question for your, I think, as I remember to your presentation was, does it appeal even now? I mean, the very high power short duration ablation in the era of the pulse field ablation. So what is your final, I mean, comment on that?
I believe it does. So we had a fairly short procedure. I mean, the procedure was extremely long because it was live, but otherwise for the ablation part, it was a relatively short procedure. With PFA, we can go down to 15 to 20 minutes of left atrial total dwell time. If you do a less detailed map at the beginning and at the end, then you lose like 5 minutes with the mapping. So the total left atrial time should not be much more than 25 to 30 minutes, even in case of larger atria. So I believe it does appeal. Thank you for the question and comment.
Congratulations, and I completely agree.
Any questions? Any questions?
No, I don't think so. So thank you again. If you agree, if there are no more comments from your side, so thank you again and congratulations. And I would like to close the session, but the problem is that we finished earlier by 1.5 hours. So and of course buses are not ready just for transport to to this evening.
And the restaurant is not ready?
Yeah, definitely. It's not likely. I will try to find Hanka Klimentova if she has any option or what to do. Otherwise, we will be waiting here, or not here, but somewhere inside, because, yes.